Nicola, good to see you and welcome.
Hello, everybody. Can you hear me?
Your presentation, yes.
All right.
Excellent. Thank you.
Okay. So, well, first of all, thank you, Prof. Chen. It has been a great pleasure to be invited here. Yesterday, the session was great. I hope today's session will be at the same level. So, can you see my presentation? Yes?
Yes, please. And can you make it presentation mode?
It is.
Yes,
okay.
click on there.
Like this?
Super. Go.
Better. All right. Okay, so let's talk about cerebellar vermis and the pathology of the posterior fossa. We have been we have seen already yesterday about what are the basic sections to obtain for a basic or advanced evaluation of the CNS. And in particular, I want to focus on the evaluation of the cerebellum and of the Cisterna magna according to the ISO guidelines. The thing is that it is not very well and very clearly stated if we need to see the vermis. Actually, what I do every time and what I recommend to do, as soon as you are at the level of the cerebellum, you go slighter down, further down, few millimeters, and you see these. What is this? Actually, this is a cut of the vermis where you can distinguish the fourth ventricle, the vermis itself, and the cisterna magna. And you can see here actually the mid-sagittal view where all these could be more clear for the majority of us. In fact, the fourth ventricle is just down here, usually is almost virtual and is this space here. The vermis that has this shape in sagittal view is this one, and then the cisterna magna just behind here, you can see here. When you see these three spaces, usually you have enough confidence to say that it's okay. These are 3 and 4D approaches that are allowing to see a more contrast view for the vermis, but I don't want to focus on this. I want to focus on anomalies. What are the main anomalies? Well, anomalies of the posterior fossa are mainly represented by the presence of too much fluid or too little fluid. Two very simple things. Too much fluid, that means that the cisterna magna is big, is above 10 millimeters, let's say. Or there is an abnormal communication between the fourth ventricle and the cisterna magna, like in this case. When we have one of these two features, we need to have a bell ringing. There could be a problem with too much fluid. On the other way around, we can have too little fluid, and we have been talking yesterday about this, with the typical banana shape of the cerebellum, typical for the Chiari 2 malformation. But I don't want to focus on this. I want to focus on cystic abnormalities. These are the 5 main cystic abnormalities that could involve the posterior fossa. Dandy-Walker malformation, isolated Vermian hypoplasia, Blake's pouch cyst, megacisterna magna, arachnoid cyst. When we go to the embryogenesis of these pathologies, the situation becomes very interesting. This is the brainstem. You can see here the roof, the floor of the fourth ventricle has a rhombic shape. And if we cut a section, this is what we see, the fourth ventricle here, the floor and the roof of the fourth ventricle. But if we cut mid-sagittally, you have these views. So this is the development of the main structures of the posterior fossa. This is actually the brainstem, and you can see here the pontine flexure, the pons. Just in front of it, actually behind it, there is this plica choroidalis that will become the choroid plexus of the fourth ventricle. It is very important because this divides the primary meninx, that is this one or this one, in two parts. The anterior membranous area and here or here, and the posterior membranous area. These two parts are having different roles in the development of the structures of the posterior fossa. The anterior membranous area will, from the AMA, the anterior membranous area, will develop the vermis that you can see here, here, here. From the posterior one, there will be this finger-shaped protrusion that is actually the Blake pouch. And after the fenestration of the foramen of Magna D, you can have here that it remains only in whole, and the cerebrospinal fluid will go into the Cisterna magna that at the beginning is forming by cavitation of the primary meninx, and later on will include also the very anechoic cerebrospinal fluid. Therefore, when there is something wrong with the AMA, we will have a problem of the vermis, either Dandy Walker or Vermian hypoplasia. When we have a problem with the posterior membranous area, we'll have the Blake pouch cyst, because it could happen that the fenestration of the foramen of Magna D will be delayed, and therefore there could be a cyst of the Blake pouch. Some authors say that also the megacisterna comes from some problem behind, around here. But what we need to seek for when we scan a patient, if we have a primary problem of the vermis size and anatomy will be abnormal. So either Vermianogenesis or hypoplasia. And the angle between the brainstem and the vermis will be abnormal. So the vermis will be upwards rotated. Another typical feature of the worst of these abnormalities of Dandy Walker is the superelevation of the tentorium, that on the other side, for the other abnormalities, is usually normal. Let's talk about the anatomy. What I want to focus on is just a couple of things. When you look at the vermis, you don't need to see all these, but if the vermis is normal, you have the fastigium, and sometimes you can also see the primary fissure that is usually a landmark to evaluate if the posterior part is normally developed, because when we have an hypoplasia, usually the vermis is small, and in particular the posterior part is small. 3D and 4D, as I've told you, they could help to see the fastigium. Here you can see the primary fissure, the secondary fissure down here. You can see a lot of details, but let's not focus on very difficult things. Let's talk about simple things to measure. If we want to measure the vermis, we can detect a small one, and these are the normal ranges of the diameters of the vermis. But actually, I can consider a bit easier to calculate the area. This has been developed by Dario Palladini a couple of years ago, has been published. The ratio between the area of the vermis and the biparietal diameter seems to be a good marker for Vermian hypoplasia. When this value, this ratio, is above 1, usually the vermis is okay. If this below 1, usually the vermis is small. And another important sign that has been developed by actually my uncle a few years ago is the angle, the brainstem to vermis angle. This seems to be much higher in the worst pathologies, such as Dandy Walker or Vermian hypoplasia, whereas is mild, is small, or almost virtual in Blake pouch and normal cases. Another landmark is the tentorium. Actually, it's difficult to visualize directly the tentorium, and the supraelevation of the tentorium could be identified when we check as a landmark the straight sinus, that is this one, or the turcular herophily. We can have an evaluation of the signal from the vein, and we can calculate the angle between the brainstem and the tentorium. When it is above 50-60 degrees, that means that is suggestive for Dandy Walker malformation. How can we see that? Well, like normal color Doppler, we can see the straight sinus, or with high resolution flow filters, we can also visualize more details such as the turcular herophily. Main features of these malformations: the Dandy Walker has small vermis, significant rotation, usually the BV angle, the brainstem to vermis angle, is above 45 degrees. The tentorium is elevated, and there is a cystic dilation of the fourth ventricle, severe dilation. I'm not going into the prognosis of these and association of these because I want to focus on the diagnosis. These are examples of, as you can see, the dilation of the fourth ventricle into the cisterna magna. And you can see here, this is the corresponding video, how small is the vermis, how wide is the angle, and we can also see another little thing, that is the position of the plexus, the choroid plexus. Because the anterior membranous area has been involved in this pathological process, usually there is an elongation of the tissue between the vermis and the plexus. Actually, it's not an elongation, but you can actually see it. You can see the plexus far away from the vermis. And some authors, they have already published this, like Dario Palladini, that is very keen to study this kind of pathologies. And you can see here the plexus that is far from the vermis. Vermian hypoplasia is characterized by a small vermis, but a mild rotation, not severe rotation. The brainstem-to-vermis angle is usually below 45 degrees. And these are examples of this pathology. This was a case with also partial agenesis of the corpus callosum that have been already discussed by Antonio. And then we have the Blake pouch cyst. Actually, the vermis here is normal. The rotation is mild, and the tentorium is in a normal position. So is slightly different, but if isolated, is usually related to a good outcome. That's why it's important to distinguish between the two. And here, for example, you can see how there has not been defenestration of the pouch, because you can see how different are the liquids in the two cavities, the pouch and the cisterna magna. And here you can see that the choroid plexus is close to the vermis, as you can see here and here in the pictures. Megacisterna magna is only a dilation of the cisterna with a width above 10 millimeters, and the vermis looks normal and is not rotated. This was a case of megacisterna magna associated with lissencephaly, small head, and as you can see here is very abnormal cortex. You can see also how different is the echogenicity, how edge cut is the echogenicity of the difference between the subcortical and the subventricular zones. This was actually another case where we had actually very borderline ventricles. We had a normal cisterna magna. We have seen again the patient a few weeks later. The cisterna magna was big, and we had realized that there was this. Actually, this is periventricular nodular heterotopia, very rare condition that is actually quite poor prognosis. And this is an example of arachnoid cyst. What are the differences? Nothing special, really, because there is compression of the vermis that otherwise is a normal one, and there is an asymmetric pressure on the posterior fossa because the cysts are like that. So I want to go towards the conclusion. I hope to be in time. I want just to focus on this two-step approach that I hope could simplify your life. There are two main things to look for: size of the vermis and angle with the brainstem. If the size is small, we look for the angle. If the angle is mild, is not wide, is below 45 degrees, then there will be an isolated vermian hypoplasia. If there is a wide angle above 45 degrees, and there is also abnormal anatomy, elevated tentorium, and other things, there probably will be a dandy Walker malformation. But on the other side, if the size is normal, then we look at the angle, mildly increased angle, Blake pouch cyst, normal angle, either megacisterna magna, or in presence of mass effect and asymmetry, there is probably an arachnoid cyst. New insights. Can we do something in the first trimester? It has been published, we have seen already this brainstem to BSOB ratio, and when there is an abnormal ratio of BS to BSOB, it could be either open spina bifida if the brainstem is thick, or if the ratio is abnormal on the other way around with a prevalence of the posterior space, there could be a cystic abnormality of the posterior fossa. In particular, if we see 2 spaces rather than 3, it is much more suggestive of a severe cystic abnormality of the posterior fossa. And these are the main authors that have been studying about this. But we can do more. We can look at the tentorium and torcular aerophily, and this has been very fresh publication from my uncle. If the tentorium is almost parallel to the brainstem, we can suspect Dandy Walker malformation. Whereas if the angle is between 40 and 50 degrees and 60 degrees, it is probably normal. We have more coming. This is the anatomy that we should see rather than 3 spaces and 4 lines. And if we look through the posterior fontanelle of the baby, we can see actually the aqueduct, the ama, the plexus, the Blake pouch. If we go transvaginally, we can see even more, a lot of more details. And if we compare with the anatomic specimens, we can see in details where is the vermis, where is the ama, where is the plexus, where is the Blake pouch. Some authors have been studying already this kind of figures and have suggested that in case of pathology, there could be an increased Ponto-Vermian angle, an abnormal aqueduct, small vermis, elongated ama. Yeah. And these are examples, yeah. And I conclude with this. Like you can see, this is probably the future, not yet the present. I hope starting from tomorrow, you will look at the size and angle of the vermis, and could be, you will start to look at the posterior fossa, at least from the bisagittal frontal view when measuring the nuchal translucency. Thank you very much.